No. Okay. Think about what we talked about in renal A&P. One of the things that we talked about was the hormones that the kidneys secrete. The one that I'm going to talk about right now is erythropoietin. Remember that erythropoietin stimulates production of the red blood cells in the bone marrow. So, when the kidneys aren't working and that's not happening, then what you have is anemia secondary to renal failure. Okay, the renal failure came first, and the kidneys stopped doing their job. They're not doing what they're supposed to do. Now, anemia secondary to renal failure is caused not only by I'm kind of giving you a grocery list here, but it's caused by failure to produce erythropoietin. You also have a shortened lifespan of red blood cells. I'll talk slow so you can write. And if you miss anything, I'll make copies of my notes. Impaired iron intake. And a lot of these people aren't feeling well. They have GI problems. So if they take oral iron supplements, they don't settle well. They have blood loss, as a tendency to bleed from the nose, the gums, GI tract, uterus, or skin. And this is due to platelet abnormalities. So, and then blood loss related to the dialysis procedure and heparin use. So anemia secondary to renal failure, it's not as simple as they don't make erythropoietin, therefore they're not making red blood cells. There are these other factors that kind of play into it. And so for that reason, we use drugs called ESAs, or erythropoietin stimulator activators. And these are drugs like Aranesp, Epogen, Procrit. The difference between Epogen and Aranesp is that Epogen is given 3 times a week in dialysis. Aranesp is given once a week, so it's a formulation that is longer acting. Okay, and both Aranesp and Epogen are recombinant forms, so this is where your DNA recombinant technology comes into play. But they are recombinant forms of erythropoietin that's normally produced by the kidney. Both drugs can be given IV or sub-Q. Dr. Kell tried at one point in time in the hemo unit to get us to give it to sub-Q to all the patients, because what happens is if you give it sub-Q, it brings the level up and it keeps it on more of an even keel. It's a longer acting effect than giving it IV. Mm-hmm. The problem is the patients didn't, we'd been giving it IV, and all of a sudden now we want to give it sub-Q. Patients didn't like that. Why do you suppose? They're getting stuck again, right? Mm-hmm. So that's not good. So the ESAs, or Epogen and Aranesp, are really important. Also, iron. You got to have iron to make blood. The form of iron that we give is ferrolicet. Other IV irons that we've given in dialysis have included Infed and Venifer. Since we give ferrolicet, I'm going to mention the dosing. Our standard dosing is 62.5 milligrams IV per week. If the ferritin or transferrin saturation level is low, then we give 125 milligrams times 8 consecutive treatments, and then drop down to the 62.5 milligrams weekly. The problem with some of these drugs, the problem especially with the ESAs, is that there are some people who are non-responders. Okay, so reasons for decreased responses. One reason is iron deficiency. That's your number one. That's the most common reason, is iron deficiency. The second reason would be infection, inflammation. It's another reason. Chronic blood loss. Now we're talking hemo patients who have chronic blood loss. Okay, why would you have chronic blood loss? Well, every time you take somebody off dialysis, you're leaving a few red blood cells in that dialyzer and in that tubing. You know, if they're not clotted, that's good, but you're still losing a little bit every time. And if you lose very much, the patient's not making it up fast enough. Then there's something called osteitis fibrosa. Who's got any clue what that is?
Bone inflammation.
Mm-hmm. Okay, osteitis would be bone inflammation, and fibrosa, it means fibrosing of the bone that can occur as the result of the inflammatory process. And so that can impair the ability to produce red blood cells. Aluminum toxicity. Remember, their kidneys aren't working, and they're not just not getting rid of metabolic waste products and fluid, but they're also not getting rid of things that have a toxic buildup, and aluminum is one of them. And then there's this big word, hemoglobinopathies. Okay, that would cover things like B12 deficiency, for example, multiple myeloma. So those are all reasons for a decreased response to ESAs. What should patient teaching include for the ESAs? Who got that for Epogen and Aranesp? What should patient teaching include?
I put on there that they need to monitor their weight and their blood pressure regularly.
Mm-hmm.
Immediately report an increase in blood pressure, sudden weight gain, or swelling. Sometimes it can cause an upset stomach, so I told them they should eat smaller, more frequent meals to help with that. I let them know that they were going to have frequent blood work when they first started, twice a week until their hemoglobin is stable between 10 and 12. And then they'll have blood work as the doctor recommends. And of course, I would ask them if they have I would find out and ask them if they have uncontrolled hypertension before giving them the prescription, because with renal patients, they have a higher rate of cardiac problems.
Mm-hmm.
And if they have a reaction to human albumin.
Good. Good.
And of
Okay.
course, signs and symptoms of allergic reaction. That's
Okay.
with everything.
Okay. Now, in the dialysis setting, we have anemia protocols that help us to determine the amounts of the ESAs that are given, and what we monitor both the hemoglobin and iron studies, the hemoglobin hematocrit and iron studies, in order to use the protocol that we have for anemia management, and that means determining from the lab work. Okay, and so the lab work would include an H&H, or hemoglobin hematocrit, and usually you'll hear us refer to hemoglobin more than anything. And then for the iron studies, the transferrin saturation. Ferritin and transferrin saturation are important, but ferritin gives you an idea of your iron stores. Transferrin saturation is more a reflection of what's bioavailable. So whatever is bioavailable, then, is what they're going to go by. So you'll increase your iron or hold your iron based on that transferrin saturation level more than anything. You might also tell the patient that they might have increased energy, better appetite, once their hemoglobin comes back up to normal.